rock and roll now. So, my name is Jill McCreary. I'm the field service rep for Territory 8, which is Albany, Macon, all the way over to Dublin, and everywhere kind of in between. We have Haley Guyton with us. She's an in-house rep, and she's on the front row. She's too shy to stand up. And then we have Shantae Lawrence and Anjanae Hall. They're going to present from DCH on their subject matter expert. So we are very thrilled to have them. We are thrilled to have you here. I'm going to start off by saying we had some questions earlier about the presentation. You can find it on our website. It's out there now. So when you get back to your office, if there's some things that you want to make sure you don't forget, pull it up, save it to your desktop. My desktop is full from here to here of too much stuff, but because I'm old, it's quick access. I can just click on my desktop and there it is. Let's see. This is the right button. All right, of course, the Department of Community Health, their mission, we should all know it by heart now. I've been doing this for about 14 years. And as it was mentioned in the opening session, their aim and their goal is to provide access to affordable, quality health care to Georgians through effective planning, purchasing, and oversight. So we are thrilled to work with them. They are most helpful, and they accomplish this mission on a daily basis, in my opinion. Our agenda today is going to be some PA stuff, PASSAR, requirements, process, Q&B, transferring from nursing home to hospice, nursing home and hospice forms, some revenue codes, timely filing, and common edits and audits. Now I'm going to pass this over to Anjanae because this is her area of expertise in the nursing home.
Good morning, everyone. Good morning. How's everyone doing? Great. Okay, so PASSARs, all things PASSAR. Before we dive in, I will go over what does PASSAR even stand for. PASSAR is the pre-admission screening and resident review. This is for all states to ensure all individuals entering a Medicaid certified nursing facility are screened for serious mental illnesses, intellectual disabilities, and related conditions. The purpose of a PASSAR is to ensure that all nursing facility applicants and residents with mental illnesses and intellectual disabilities are, 1, identified, placed appropriately, and provided with the needed services. PASSARs applies to all applicants of Medicaid certified nursing homes, regardless of the method of payment. The responsibilities. PASSAR enables the Georgia Department of Community Health, which is us, to be compliant with federal PASSAR regulations, which state that an applicant should not be admitted to a nursing facility for long-term care until the Level 1 or Level 2 PASSAR has been approved. PASSAR enables assurance that applicants can be appropriately served in a nursing facility, especially with the presence of a significant mental illness, intellectual disability, and related condition. We at DCH, we track the compliance with PASSARs and substantiate the integrity of the nursing facility claims. So now we talked about what does PASSAR stand for. Let's transition into the flow. The flow of the PASSAR, The provider submits the PASSAR, step number 1. The Level 1 PASSAR is reviewed by Alliant Health Solutions. We contract with Alliant and as well as Beacon. If the PASSAR is approved at level 1. The pre-cert number is given via either the medical reviewer portal, or you can call to find out the pre-cert number. If it's not approved for admission, it goes into the pending status. Reasons for pending status: premature admits, if the MD signature is greater than the 30 days of the admission date for the nursing admission, excuse me. So if the person is admitted and 30 days later the physician's signature is greater than the 30 days, then it will go to the pending status. And also any duplicates, their PASSARs are reviewed every 90 days. And or if the PASSAR needs to be screened for a level 2. If a level 2 triggers, the Omnibus Budget Reconciliation Act, OBRA form is completed by the reviewer, and that's when Beacon steps in. Beacon will then contact the provider, request for medical records, and conduct an assessment as needed. Beacon has at least 7 business days after receiving the assessment, after receiving the information to complete an assessment. Beacon then sends a copy to make the final decision to the facility and the individual. If mental health services are needed, it's the nursing facility's responsibility to contact a mental health provider. The PASSAR process. If a resident is admitted to a nursing facility and the expected stay is less than 30 days, and there is other health insurance coverage in place for those 30 days, a DMA 613 is not required. However, if the provider expects to be able to bill Medicaid for any of those 30 days, a DMA 613 should be submitted. And that will then trigger the creation of a level 1 or level 2 PASSAR. The completion of the level 1 or level 2 PASSAR screening is mandatory to receive prior authorization. I know we just reviewed this, but let's come back to it again. Pending status for PASSARs. If the physician's signature is greater than 30 days from the date of admission or the date the PASSAR was submitted, pending status. If for any reason that you answered yes for a mental illness, dementia, developmental disability, intellectual disability, and related conditions, PASSAR is pending. Any possible duplicates, PASSAR is pending. And also, if the patient has already been admitted to a nursing facility, the PASSAR will be pending. Our partnerships, as I said previously, Alliant Health Solutions partners with DCH to review all level 1 PASSARs. And here's their information. Beacon Health Options also partners with us specifically for our level 2 authorizations. And here's their information. Transitioning into QMB, qualified Medicare beneficiaries, Medicaid recipients are not required to apply for a nursing home Medicaid. However, Medicaid will pay second after Medicare to cover the QMB recipients' Medicare coinsurance and deductibles. Please note, after the first 100 days of a benefit period, QMB recipients will be responsible for all cost for each day thereafter. Since many applicants enter nursing homes from swing beds and skilled nursing facilities, some of the 100 days may be used prior to being admitted to the nursing home. If the Medicare payment on a claim is equal or greater than the Medicaid maximum allowable amount, Medicaid will not pay anything on that claim. Lastly, when a QMB recipient is admitted to a nursing facility under Medicare skilled nursing facility care, the nursing facility will complete a DMA 59, sections 1, 2, and 3. So ways you can submit the DMA 59, you can fax it, but there's also a way to submit it via the Gateway portal. And that is my time. I'm going to transition it over to Shantae to cover hospice services. Thank you. Oh, we're going to save questions for at the completion. Thank you.
We'll get to your questions when I close it out at the very end. We're just going to save the questions to the end so that we don't get so wrapped up in questions we can't go through the entire presentation. So bear with us, but we will address your questions.
Good morning, everyone. Good morning. So again, my name is Shantae Lawrence, and I do oversee the hospice program. So it's nice to see all of your faces today. I do have a question. I would like to know, with the hands, how many people in the audience are hospice providers? Y'all just ready to light me up today. I know y'all. And how many of you guys are nursing facility providers? Okay. All right, pass art? All the same, okay. So, without further ado, I want to go ahead and just get into the presentation and talk about hospice services. What I plan to do is just give some basics, and then we're going to talk about some of the trending topics in hospice. So if you're a seasoned provider, hopefully you won't be too bored with this presentation, because sometimes we try to aim to educate our newer providers as well. So at the end, I know you guys, you're going to address your questions or concerns about things I probably don't touch on, and that's okay during the Q&A. Okay? So bear with me. I'm sorry. So let's talk a little bit about the scope of hospice services and who qualifies to receive them. So what I'll start by saying is that the hospice program, as many of you all may already know, is a very multifaceted program, and it consists of a lot of moving parts to get a member on board and to continue throughout the program. But first, let's just address what hospice services are. Hospice services are forms of palliative care designed to meet many needs, such as social, physical, psychological, emotional, and spiritual needs of terminally ill individuals. To qualify for hospice, the member must be Medicaid eligible and certified as terminally ill by a physician with a prognosis of 6 months or less to live. Okay, here we go. Sorry about that. Okay, so before I get into this part, I want to say that hospice consists of, again, many moving parts. So there's the eligibility piece that must take place for the member, and then there's, of course, a hospice lock-in. So what is a hospice lock-in? The lock-in was created to essentially make sure the member is getting only end-of-life care, because end-of-life care and curative care is two different things. If a member is in the end-of-life care program, the curative care should not be provided, because it can essentially become a duplication of services. So that's where the term locked in comes from. We want to lock the member into these services only to prevent that issue from happening. So with that said, again, we have the eligibility, and then we have the lock-in process. The lock-in span, once the member is eligible, the lock-in span lasts for 13 months. And at that point, the physician is to recertify that member every 90 days. So the certification period goes 90 days, 60 days, and then that kind of continues out until the member is no longer on hospice services. And the certification periods, we're going to be honest, is also put into place to avoid a lot of fraud and abuse in the program, because sometimes a member the illness will become, the health will increase, we'll say that, and they will no longer need access to the program. So the goal is to move them on to another program and give them curative care treatments. So that's why we have the certification periods. I know a lot of people harp on that, and that's also why we have the lock-in present. So I want to be transparent about that. So with that said, I'll go ahead and get into this particular slide. This is why we are addressing the hospice Medicaid eligibility piece. So first and foremost, the member must have supplemental security income, Medicaid, or age, blind, and disabled Medicaid to be eligible for hospice services. And the only time that Gainwell Technologies can apply a hospice lock-in without the ABD Medicaid is if the member has SSI Medicaid. All right, so, sorry, wrong way, forgive me. This slide here is basically to piggyback off the last slide. It's more so a visual of exactly what I just said. And this is a snippet from a process flow chart that I created many years ago. And that process flow chart pretty much goes from the beginning process from when a member is eligible for hospice all the way over into the lock-in process. Now, as you all know, the seasoned providers, the process is way longer than what you're seeing right here. There's so many other things that can take place in between this process, and that's why the flow chart was created, to give you more of a visual of what you're seeing in the actual manual. And I know that manual is pretty long, so that's why that was created. Please go on the GAMIS website and utilize those resources that are there. Not just the manual, but the frequently asked questions documents. This flow chart is there for you guys as well. So let's go ahead and get into why this is here. So I separated SSI Medicaid and ABD Medicaid. As you can see, the first step in both of them are the same. The hospice provider must submit, oh gosh, what did I do? I'm just messing this thing up today. Uh-oh. Okay. Yeah, something. I think I touched this tool. Thank you, Dan. So, sorry about that. So, as you can see, oh, I'm missing something. There we go. Okay. So as you all can see, the first step on both sides is the same. The provider must submit all necessary documentation to both DFACS and Gainwell Technologies. These forms consist of the hospice selection form, which is the DMA 579. We have our hospice care communicator, which is the DMA 527A. And then we have our DMA 59, which is the nursing facility reimbursement form. Only for those members that's receiving care in a nursing facility with room and board, of course. So, the first question we ask is, has all these documents been sent to both Gainwell and DFACS? If the answer is yes, for the SSI member, then Gainwell can go ahead and approve the lock-in, considering everything is what it needs to be. And that side, the SSI Medicaid process is that simple. Now we look over at the ABD Medicaid side, and as you can see, there's an additional step in the middle. And it is because DFACS has to apply an appropriate aid category for Gainwell to be able to apply the lock-in. So anytime you have an ABD Medicaid member, that process may be a little more lengthy. As you all know, when you're dealing with those two, one process is a little easier than the other. So I just wanted to give that visual for you all. We'll move along. Okay. So now that we talked about the hospice eligibility piece in this two-part process, we'll talk a little bit more about the hospice lock-in. So let's say you sent off your documentation to Gainwell Technologies, and they're reviewing your documentation to decide if it will be approved or denied. So the next step would be Gainwell Technologies will communicate to you all through a member enrollment acknowledgement letter. And this letter pretty much serves as a confirmation of receipt, or it can be reasons for rejection. It can be for a missing signature or a missing date or simply submitting the wrong form. But it's their way of communicating with you all about the status of your documentation. And it's also used as a proof of timely submission. Also you're gonna hear this a couple times. Please note, the election forms received past 30 days time frame are only approved on the date of receipt. Not the date that you requested, not the date that the member has elected to receive hospice services. And I have to elaborate on that because I know sometimes providers want to challenge that they sent in their documentation late and they want to change that date. Unfortunately, there technically is no appeal process for it, but I know providers still will go in and try to appeal that. I just wanted to reiterate, it's very important to make sure you're getting your documentation in on time. Okay, so now let's look at, when it comes to the eligibility piece, what aid categories are we looking for in the GANIT system when we're wanting to see if our members have the updated aid category or eligibility that should be in place. So for ABD Medicaid categories, my tip is always 2 equals ABD, 3 equals SSI. So aid categories 280 through 292 will be for home hospice and institutionalized hospice. Institutionalized hospice can be nursing facility, hospice facility, and for SSI, as you can see, aid categories are only 301 through 303. SSI is just always more simple, huh? All right, so moving along, to certify for a hospice lock-in, the following forms must be signed and dated by a physician or a medical director. And we've already pretty much talked about these forms, so we'll move along. And now, so we're going to get into our trending topics here. Let's talk a little bit about revenue codes. Revenue codes 651 through 652 and 655 through 656. And so let's get into a scenario here so we can get some understanding behind this. The reimbursement rules for revenue codes 651 and 652 are based on the member's geographical location. The reimbursement rules for revenue codes 655 and 656 are based on the provider's geographical location. So for example, if the member is receiving services in a general inpatient care setting, and we're using revenue code 656, the provider is located in Region 3. However, the service was provided in Region 8. How should this claim pay? Should it pay based on the member's location or should it pay based on the provider's location?
Member.
The claim should be paid based on the provider's location in this particular scenario. So if the service is for instance, if the service is for routine home care and the revenue code is 651, the member is receiving hospice care at home. So the claim will pay in that region that the member is located. Does that make sense? We can get into more detail about that. So I don't want to, yeah. Because this particular example is, again, the provider is located in Region 3. So that can be considered hospice, nursing facility, or home. However, the service is provided in Region 8, inpatient hospital. So that is the provider, right? So the provider's location is where the service is provided. Does that make sense? No? Okay, we'll come back around to it. I'm sorry, yeah, I don't want to confuse you guys, but we can come back around to it. Okay, all right. So let's go over this part and let's see if it brings some clarity here for you guys. So rates are not based off the hospital, but the member could be in the hospital in their hospice ward. They could also be in the home, the nursing home, or a hospice facility. The point being, the service may not necessarily be provided in the same geographical area as the provider. So as seen in the previous example, the provider was in one region and the service was provided in another. Revenue code 651 was paid for region 8, however, revenue code 656 was paid for region 3. Still confusing? Okay, we'll come back to it. All right, so the next trending topic is the member, and that's why I brought it up. So we're gonna talk about the next slide. It is based off a member being in a nursing home and electing to receive hospice mid-month. And the key word here is mid-month, because that's usually where the issue lies. So the first thing that we can take away is that nursing home Medicaid always takes priority, and it carries the full month. So that means the hospice eligibility update will occur the following month, on the first day of the following month. And remember, this is because the nursing home can't bill on hospice Medicaid, but hospice can bill on the nursing home. So that is why this process is the way that it is. But again, lock-ins will be applied on the day that the member elects hospice, given that all documentation was complete, legibly signed, and submitted within the 30 days. Okay, so also, please note that providers are not permitted to stand bill. So let's really get into it. What is stand billing? Stand billing is when you provide services to a member for, let's say, a few days, but then you want to bill for the entire month. So if services were rendered from the 1st through the 18th, you are not allowed to bill through the end of the month. And it is your responsibility as a provider to keep your claims timely. You should not wait for any hospice eligibility updates or any lock-in updates to bill for services rendered. You always go ahead and bill your members timely, keep those claims alive. If we have to override timely filing for anything on our behalf, we are happy to do that. And the reason why I picked this topic as well is because a lot of the times a provider will come to us frustrated that they cannot get paid. And the issue is because electing in the middle, I'm sorry, let me go back. Okay, don't want to confuse you guys. So if you stand bill for days that you did not provide care, and another provider has to come in and provide care, they cannot bill for that member's services. And then they're coming frustrated saying, hey, someone else has this member, it has been paid for them, how do we get paid? And then we have to go and do our research and find out who got paid and why. And then so we have to have that provider work it out with the other provider and provide reimbursement, and that's just never a fun time. So we always ask that providers do not stand bill, do not anticipate services, only bill for the dates of services that you are caring for. Okay, so our last training topic here is a member expiring before achieving hospice eligibility. In the event that a member expires before achieving hospice eligibility, the member will not receive a hospice eligibility update from DFACS. And this is why, because when vital statistics goes in the Gainwell panel in the portal and updates a date of death for that member, it no longer allows DFACS the access to go in and make updates in that capacity. So that then creates what we call a date of death lock-in. And that basically allows the member to get a lock-in from the first day of service until the date of death. And this lock-in is pretty much the same as any other lock-in. The only difference is that we encourage providers to notate on the documentation that they would like a lock-in from the first day of service until the date of death. And again, all forms must be complete, legibly signed, and submitted within the 30-day time frame of electing hospice services. And now I'm going to go ahead and turn it back to Jill McCrary to bring us on home. and then open it up for questions.
Thank you. All right, I'm gonna take the reins again, and we're gonna talk about a little Gamewell housekeeping, adjudication housekeeping. I do want to mention questions at the end. I should have done that at the beginning, my mistake. And you were given a survey. If you will, please fill that out and leave it at the door. So, some housekeeping for us. As far as claims adjudication goes, I touched the cord. Leave it to me. I say I'm the old lady that's technically challenged.
While they're doing that, did everyone receive a yellow form? You did not
Survey, please. It means the world to us if you'll go forward. All right, thank you, Danny. What would we do without Danny? Working those denials. Nobody likes denials, and you'll have to understand I come from the claim side, so that's what I am most familiar with. Exact duplicate, pretty self-explanatory. We've gotten it before, something has happened to trigger this, something is in our system from a previous claim. Most of us, of course, know how to fix that. We need to look back and see what it's duping to. If you can't figure it out, call your provider rep. We'll see what it's duping to, and we will go from there. Nursing facility ID is invalid. You know we're a number-driven society, so please always check those numbers and make sure that's a really easy fix. Member ineligible, I cannot state enough, and I tell my providers this every time I go for a visit, don't render a service without checking eligibility. I mean, push comes to shove, don't render a service without checking eligibility. It is imperative if you want to get paid, and you know, most of us do. So that is a core statement level. Check that, check it every time, because eligibility is updated every day. So don't make assumptions. You know what we all get in trouble for, making assumptions. Header, attending physician, provider not eligible. Check what you put in your system and verify that you've got the right provider that is eligible. Timely filing, let's touch on that a minute. Failure to file your claim within the 6 months, you're going to get zapped. Now, of course, like Shantae said, there's always exceptions. If a member has a type of Medicaid in GAMIS, QMB, SLMB, S99, during the time in which a member is in a nursing home facility, the provider is supposed to bill and receive those denials, which will lock in their rendering service span, dates, and prevent claims from denying time. And once again, long-term care eligibility is established and claims are processed in the cycle as the system is designed to do. Now, like Shantae mentioned earlier, get that claim in there. It doesn't matter if you know for sure they're locked in, or you know for sure whatever. Get that claim in there. I touched it. And make sure you're filing those claims. Let them hit the wall and deny. It doesn't matter. We've got them in there so that whenever the lock-in or what it is corrected, updated, you're locked in. Yay, 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 hip hip hooray. We can hit resubmit or send that claim through again, and it should process. Now, let's add a caveat to that, and I'm afraid I'm running out of time, so I'm not going to expand on this too much. But as mentioned earlier, if for some reason it's taking the lock-in a little bit longer than anticipated, expected, we're going a little bit of a back and forth, always come to your rep or do a DMA 520. That's your first level, is that DMA 520. You should be able to ask for an override of timing, saying, we sent the paperwork in, for some reason it took this long. He came in April the 1st, but his eligibility wasn't updated until October the 4th. Do a DMA 520. You will have a little blue button on your claim by the member number or name up there on the left. Do that DMA 520. That way you won't have to wait on us. You won't have to do a contact us. It will really increase your turnaround time. I mean, slow down, make your turnaround time a whole lot less if you do that DMA 520. So I do want to throw that in there about how important it is. No, it's not a form. It's on your claim. It's on the claim up there by your member number. You'll see do what? ICN number over there in that general area. And you'll see it's in a blue block. And you'll click on the block.
What's the other block after that when it's denied? Can you tell us what that block, what that other block is?
Like a DMA 520A? I'm not sure.
Like if the DMA 520 denied, then you need to do another.
You'd have to do an appeal. Administrative review, yeah. Yeah, administrative review. I'm sorry, yeah, that's the next step. I thought you were, yeah. And providers should review the timely filing policy outlined in section 202 of the manuals. As I mentioned in the opening session, the manuals are being updated. DCH has phenomenal manuals. Let me just lay that out right here. 99% of everything you need to know is in a DCH manual. They work fervently to keep those manuals updated, and we need to work fervently to peruse and review that information because it is there. It's in the manuals. When I first started working, I'd go to DCH and ask a question. They would say, Jill, have you read the manual? No, I don't want to read it, but reading is imperative. We need to read those manuals, period. Some more, just a list of the really common stuff. PA pre-cert not on file, you can look that up. If it's not in there, we've got a problem. So you can look up your PA. Date of service doesn't fall within it. Hospice claim spans member hospice segments. Member has elected to receive hospice. Member is ineligible, rendered provider not listed, member not eligible for nursing home. We all know these. If you've been doing this 6 months, you know these by heart. We know what we need to fix, and we need to go in there and fix it. You can fix it on our web portal. I mean, pull up the ICN, log in, bam, fix it, and you got your $7,000 or your $1,200 or whatever your payment would be. Fax documents must have the member ID. Please ensure all forms are completed and legible. Diagnosis must be very clear. Provider IDs have to be on the form. I cannot stress that enough. Something so basic. And here's the fax number. Now, we have entities involved. We have DCH, DFAX, and Gangway. So here's just a little breakdown of what each one does. And as I mentioned, this is currently on our web portal. So you can pull it up and review it when you get back if you saw something you want to make note of. Or as my best friend used to say, put on a cheat sheet. That was her favorite thing to say, put on a cheat sheet. Policy information and updates, check for updates frequently. Banner messages, check them. Go on the web portal, they're there. I tell my providers to go at least once a week. I don't care if you do it on a Monday, I don't care if you do it on a Friday. They're put out there all the time. But just go check them because it might be something you really need to know, or a process you really need to know, or a way to get your rate increase that you really want to know. So check those banner messages. Refer to your provider notices under provider information tab, and then manuals are updated quarterly. Trust me, I know. Manuals are updated quarterly. And the cool thing now about manuals is what's changed is in the front. So you don't have to do like we used to have to do and go Control F and put in 04/24 to see. They're listed in the front of the manual. Now, graciously, we have had today with us two phenomenal representatives from the Department of Community Health who have done a phenomenal job. Anjanae has done a great job on nursing. Shantae, bless her heart. Oh my gosh, she knows every one of us like the back of her hand. And you talk about respond. They're just a bomb. So you have two very valuable assets here at the Department of Community Health. If you have a question that you don't think your Gainwell rep can handle, you know, we would ask, of course, since we adjudicate the claim, that you come to us and let us see. But if it's something that you think you need to go to them for, they will take your call or email without hesitation. Our 800 number has been the same for years. Prompts have been the same for years. Not much has changed. There's the 800 number. And then I will go into a contact us. Now, contact us is the preferable method of getting in touch with us. The state wants to know how we're doing and holds us accountable for our response time. So a contact us gives you a contact us number, comes to us, and then we can respond within that 72 business hours. And this is how you can get to us, specifically your rep. Contact my provider rep or request a provider rep visit. That's going to come to us to work. Gabby is something new. It's an interactive voice option. They picked me to help implement it, and you know why? I know you can't guess because I got such a country accent. They said, Jill, we need you because if Gabby can understand you, they can understand anybody. It's like, okay, then I will not take this personal. But Gabby is helpful. Go through it, go through the prompts. Eventually you'll get to where you want to go. If not, it's going to send you to somebody. Now you met all of us at the very beginning. This is the 10 reps, and we have 2 hospital reps. We have statewide consultants, who is Danny, that came in to save the day. I can't see good enough to know if Brenda's here, but she's another one. So they step in and help us sometimes when there's a major something going on, or there's an issue that needs a lot of in-depth research. That's where they come in and help us. Now, the big thing, question and answers. I'm going to get Haley to walk around with a microphone, and we're going to do this in such a nice way, such a nice, organized way. If you will put your hand up, we are going to we see you, I promise. We're going to let Haley come to you. And, of course, we've got good representation, so go for it.
My very first and most important question is, how do we, if we have a hospice transfer, and we're unable to do a transfer on the date that we originally said we would, but the previous hospice is refusing to help us close the gap, how do we fix that? Because we're a new hospice provider, and we've had to backdate our claims, our provider number. So we're having a problem with some transfers not getting the benefit period close if you're unable to do the transfer that we originally said we were going to do. And the previous hospice is refusing to close the benefit period, so it's blocking the patient from using their benefit.
So this is basically an issue with a transition and an issue with the communication between yourself and another provider. So typically, I mean, it happens from time to time, and of course, there's nothing we can do. You can't force anyone to do anything. However, I'm always here to advocate for you all, so if there's ever a situation where you're having a hard time communicating with another provider to get the care for your member, then contact me, and I'll do my best to advocate on your behalf. I've done it many times before, and I will say that sometimes it's not going to be difficult. A lot of providers are uneducated on the process and don't know what to do or what to fill out to get that from under their care. So always reach out to me if you're having that issue. I say after the second time of you trying to communicate, go ahead and just bring it on over. I'm happy to help.
It's on the presentation, the contact. Yeah.
The first question is gate. I have coworkers who used to log in. I know Ms. Beasley used to do that. I called her, no answer. Email, haven't heard back. So is someone new is doing that or what?
Your question is,
Gateway, how do you get
a login for?
No, how do you get a coworker, a login for Gateway, access to Gateway? You know how when we upload communicators? Gateway.
My name is Bradley
Ms.
Green.
Beasley used to do that.
Medicaid Policy Unit Director.
Say that again?
My name is Bradley Green. I am the de facto Medicaid Policy Unit Director. The Medicaid Provider Portal, I think is what you're talking about, right?
No, Gateway. It's not Gaines.
No, I'm not talking about Gaines. I'm talking about Gateway. The Medicaid Provider Portal, that's what we call it. We have Customer Portal, a Community Partner Portal, and then the Medicaid Provider Portal. That's for nursing homes, hospice providers, and waiver program providers only. Is that what you're talking about? Yes. What Chandria, Ms. Beasley used to do?
No, if you needed access, a login, she would do that and send it to you.
Yes.
Used to.
She,
Oh, so she does it now?
no, she was in my unit.
Okay.
She handled that.
Right.
Since she's moved to DCH, we've had to have an interim person in our unit to grant access to providers for what we call the Medicaid Provider Portal. It's a secure part of Gateway that does that. Now, that particular person has been out for the last week unexpectedly, I know. How long have you been trying to try?
For the last couple of weeks, but I said it to Ms. Beasley, not that
Okay,
other person who
Yeah,
was talking
don't go
about.
to any, sorry.
I tried as well, and I'm just Melissa Wade.
Yes, Melissa Wade, she's been out the last week, but there should be one of her workers who is interimly backing up to capture all of those. And she's working on those as quickly as she can because she's handling a lot of the SNU issues that we have and some other things.
Okay, can you give me the email I need to send it to?
All right, if I can remember this correctly, Georgia Gateway MP at DHS. Georgia, you spell it out, Georgia Gateway, Michael. Georgia Gateway, MP, the letters MP like Michael Paul, all together.
Write it right now, because I need that.
At DHS .ga.gov. Ms. Wade should be back with us next week. And
Okay.
We'll be able to have that. We'll transition her work back to her after having to get out of the But there is somebody who's trying to cover for that. And it's just that she has so much other stuff that's coming at her as well. We're trying to get to these as quickly as we can.
So we just have to be patient.
Please.
Okay, thank you. Okay, second question is, the letters that we receive, they come with a client ID. And when I go on Gateway, it's like you need your date of birth and social security number in order to figure out who that patient is. How do we find out what patient that letter pertains to?
Gateway or Gaines? Is this for Gateway or Gaines?
Thank you.
Teamwork. Hey,
You know how we do walk in, the patient was walked in, the patient was approved. I couldn't go on and bill because I didn't have a Medicaid number. So when I got that and I finally billed, it was dead and fine. I called contact us, they was like, oh Tracy, since you have a bill, you can't override it. And so what I should have done was do the DMH 520.
Yes.
Can I still do it?
Yes, you should be able to do it, yes.
So that's, okay. Okay.
Yeah, because they didn't walk it out.
It's right by the ICU.
Thank you.
I wasn't dealing from
Well, for the inpatient thing that you were referring to, so we now have like the inpatient in there at Emory with Capstone. So were you saying if we have a patient there, we need to be using the hospital's counting for the lock-in?
So, and that's why I brought the scenario up, because it gives a lot of confusion half the time. I think the key thing to remember is that Revenue Code 656 is the provider's location. Revenue Code 651, member's location. So with that being said, if you go in the hospice manual, and let's say you do control find and you type in the word region, you'll find, it'll show you exactly what you need to know. It'll show you what region is going to be used for what you're billing, based on that area that you're billing for.
Just clarification. So if the patient lives in region 3, right, and they're being serviced in region 8, we're going to bill region or use revenue code for region 3 based on the member's address.
Location. Because where are they, they could be at home, they could be in a facility.
So that's what I'm asking.
Yes.
The slides are the opposite of that.
Say that last part.
If we're using revenue code for the ICU location, because that's where the patient's located, the slides are the opposite of that.
The patient is in a hospital.
Uh-huh.
That's our
Revenue code 656 specifically. The patient was at home, then they went to the hospital and they're receiving hospital care, general inpatient care. Then are we gonna still build a home revenue?
No.
Home service location?
If you are using Revenue Code 656, you're billing the provider's location. So wherever the member is receiving this,
The hospice provider or the hospital?
where the member is receiving the services. So it will be the hospital. So the key thing to remember is where the services are being provided.
Do we have to update our walk-in if the patient goes to the hospital? Do we have to update the service location?
No,
Cameras and evacs?
no,
Okay.
no, you shouldn't have to do that. Is that more clear for you guys? I hate to confuse you, but that's why I brought it up. So
Provider though, we're the hospice provider. The hospital is just the service location. That's where the confusion is coming.
well, provider means whoever is providing the care. It doesn't always mean you, because if you're sending your member somewhere else, they're now the provider.
No, we're going in and servicing, our nurses are going in and servicing the patient at the hospital.
At the hospital.
In this hospital service location.
Right.
Yeah, we're talking about that location then, not
Where they're seeing the patient, not where
Yes,
you're
not where-
the provider are located.
That's what we've been doing, so that's why we were confused, it's like you're saying the provider, but we're the hospice provider.
It's just the wording.
Yes, it's
Oh,
the-
you're getting
you're-
fine?
yes.
Not, you're doing it fine.
Yeah, exactly.
So far, we haven't, I personally haven't had.
Yeah,
So the system is paying correctly and you're billing
I
correctly.
haven't had GIP patients yet because we're the provider.
Okay.
I mean, we've been in business almost a year, but we just are hitting all of our backlogs and stuff.
yeah, it's wherever you as the person providing the service, let's take provider out of it. You, the person providing the location where you're going to see, yes.
So it's a service location versus provider.
Right.
Correct.
I have one question based on the situation we're dealing with right now. There was a patient who went to the hospital and got emergency Medicaid. Now we're dealing with a situation where the same patient now wants to move from their home into a facility, and the Medicaid states they're just pending. So we don't know if we should go ahead and tell them to go ahead and move into the facility with the Medicaid being pending and not approved yet, or as to
Oh, I got it.
Even, yeah, if you
say we have to upload the data. Yeah, so all thing you have to do is upload your history.
All right, let's go to this. Yeah, but EMA, remember EMA is unto itself, so you've got specific parameters on EMA.
I'm speaking on behalf of a nursing home. Okay, let's say I have 80 patients who want to admit today. They're applying for Medicaid, it's pending. And they're also admitted to hospice the same day. So quite naturally, so let's say they get approved for Medicaid 4 months down the road. So you're saying that I, as a nursing home, should go ahead and bill regardless? Because typically what happens is that the hospice provider pays me, and they don't bill. So something I'm hearing is that regardless, I need to go ahead and bill regardless.
We're just saying, don't wait for updates from defects or annual technologies to bill for your member. If you're providing the service, you can bill for your member.
But here's the thing though, let's say that person gets approved for Medicaid 3 months down the road, and the eligibility table is locked in to, I'm just gonna use Capstone Hospice. So if, I could bill that claim anyway, if it's locked in the Capstone Hospice.
Or should the hospice be the one billing the claims? That when
If
the
there's-
patient is Medicaid pending, the hospice provider is not gonna pay for the Medicaid.
Exactly, so how, and me as a provider, I mean, how can I go ahead and do the claim? Because they're gonna be one, on the eligibility table, is gonna have Capstone Hospice locked in. So typically, I wouldn't bill
I'm
that.
gonna intervene here. All right, so timely filing is you have to get that claim into our system. If you are expecting payment, you have to bill that claim timely and keep it timely every 90 days until everything is resolved for you to be paid. So
Regardless,
whomever do payment needs to bill that claim and keep it timely until whatever is resolved.
So I will complicate things if when hospice gets locked in, would I create problems for hospice?
No,
We
the
just
other
need
one
you-
would have to go back, if they got paid incorrectly, they will have to go void that claim. And once that claim is voided, your claim will be your claim will be filed in time, for you to go in and do the DMA 520.
We need to hold this question, Jill. We need to hold this question. Anyone else have a question?
You can email me with additional questions, but we want to get everybody in the room.
Or you can come see us at the end.
Yeah.
Next question, please.
So I have a question related to the PHE unwinding. So since the PHE unwinding occurred, we have a lot of 2023 claims that are pending lock-ins. Can I still submit that DMA 520 for every single one of those, even though we do not have our lock-ins? We have a lot of 2023 claims that they're billing timely. They are getting denied, but one of the issues with that is when they finally get that lock-in, we're getting another denial saying it's past time.
It's past the 365 days allowed.
365, yes. And we can't control that. So what do we need to do as far as that is concerned?
So because you kept it timely and you get with your rep, we're gonna actually fill out a spreadsheet with all the latest ICNs and we'll get it processed for you. Perfect. Next question, please.
Thank you.
Okay, so we are a nursing home that has our own, we have nursing homes and we have our own hospice provider. So we have no problems with locking in when somebody elects hospice. Our problem is when somebody disenrolls from hospice and getting payment. Our company is writing off thousands of dollars every month because there can only be one class of assistance, right? So if the hospice can get paid on nursing home, but nursing home can't get paid on hospice. So if we have somebody that revokes hospice on the 15th of the month and goes back to nursing home coverage, there is no way for us to get paid for those 15 days for the rest of the month. And that's been, I know that started back when we were at Medicaid Fair in Tifton is whenever we came across this issue.
Yeah, you're gonna, if you could email me, we'll talk further about that. It's
all right, I did it. I'm gonna see what happens. I'm only gonna do that one.
Have you contacted your Gainwell,
We have been every, we have taken it to the state.
Well, do it one more time.
do you know who your provider rep is?
I do.
Who is it?
Carolyn.
Send an email to Carolyn.
But we get tired of saying, you know, it's on the vote time.
Danny Williams.
So the other part of that issue is, if they revoke on the 15th, if you try to go to your court,
Everybody can't.
I'm sorry, who's talking? I can't.
I have the mic.
Okay, go ahead.
So the other part to that issue is if they revoke hospice on the 15th, if Candace does get updated, the 15th is still locked into hospice in the nursing home. So what we do is we'll bill the claim from the 16th through the end of the month, and we will get paid, but nobody will get paid for that day that they revoke.
Yeah.
So that's the issue. How can we fix that? Because if you're trying to bill from the 15th, from the day they revoke to the end of the month, it is going to deny, but it's denying it only for the one day. So adjust the claim to exclude the revocation date.
But our problem is that month that we're looking at, it says institutionalized hospice and never goes back. They won't change it back to say nursing home so that we can get paid.
Okay.
That's the problem. It
Ours is
only
just
goes to
one
one,
day.
like we can get them locked in and billed, but we can't go backwards. I can't make it, the whole state.
So how can we?
It sounds like an eligibility issue that you're speaking to. And we do have a contact list for that. If you email me, I can provide it to you. The admin in your territory that you can reach out to get help, get assistance with getting that corrected.
So what about the revocation date?
Let's give them a chance. Somebody else have a question?
Yeah, so what about the revocation date? How do we fix that issue with the nursing home not being able to bill on the date that the resident revoked hospice? Because hospice doesn't bill that day because they're revoked. But that day is still locked into the hospice company and the nursing home. So that's one day that nobody can bill for. So how do we fix that issue?
It sounds like this is something you have to reach out to your Gainwell territory rep about, because it sounds like there needs to be a correction in the date of revocation.
They issued a date that they actually revocated, which hospice does
When I
not
see you,
bill for.
they trying to make it like they got it all together. No, they don't.
Right, that's their discharge date. But because that date is there, and the nursing home cannot bill that one day.
Y'all should be knowledgeable enough to say this.
Yes. Yes. Are you doing that the day before or the day of? Right, okay. No, I was asking her.
That's all we'll have an issue.
Yes.
They got this thing. That's when we had that leadership training. They gave everybody one.
Correct. So that is the answer to your question.
Hold on, let me get my bag.
Ma'am?
You made the bag later.
All right, so we
Turn my face.
Oh, sorry.
You don't get it all one.